Okay.
I think we can start. Lalita, you can start, please.
So I request you and Amit can start, and then I can introduce sir, and then we can take it forward.
Okay. Good morning, everybody. Welcome to the MAPMR monthly webinar series. This is a new initiative of the MAPMR to spread knowledge among younger colleagues. The aim is to focus on key important topics which are being part of daily life of residents and younger faculties, faculties of PMNR. To thank the MAPMR Executive Committee for taking this initiative. Thank you, Amit, Priyanka, Nitin, Navita, for this gesture. Thank you very much.
Thank you so much, Dr. Srivastav, and I think so Dr. Amit has joined. We're just waiting for him. There's some connectivity issues, but keeping in mind the time, we can start our first academic session of the year, which is spinal cord injury rehab. Asmita, can we have the CV slide? So our first speaker and our mentor is Dr. Anil Gaur, sir, and he is the director of All India Institute of Physical Medicine and Rehab in Mumbai. And his areas of specialization is spinal cord injury rehab, surgical rehab, accessibility. He has large number of publications, 34 publications in national and international journals, and 2 chapters, in chapters, 2 books. He's a member of many various organizations, including IAPMR, IPRM, ISCOS, IMA, and IFNR. So I'm sure this will be a very fruitful session for all of us and the PG especially. So I request sir to start his talk. Thank you so much.
Thank you, Dr. Navita. Yeah. My topic today is advances in SCI rehabilitation. Spinal cord injury. Most of the spinal cord injury cases are traumatic. Approximately 90% of the spinal cord is damaged by 90% of cases is damaged by injuries. That's traumatic. When we talk about spinal cord injury, the most common problem is the prognosis, whether the patient is going to improve or not. Because till now we have been finding it difficult to decide whether this patient is going to improve or not. So prognosis is primarily determined by the extent. We know, all of us must have seen in our practice that depending on the damage, how much the damage has been, the prognosis can still be predicted to some extent, but not totally. The neurological recovery which is the most important thing in case of spinal cord injury, that is not influenced by what we usually think is the fracture type, neither is influenced by the use of steroids. Though I'll come to that, it has been said that steroids, when used initially in the beginning, in the initial phase, are useful. And the signal changes observed on MRI. Even MRI cannot tell us whether what is the prognosis would be. We go back to our knowledge of histology. Spinal cord, if we see, it has got anterior horn, posterior horn, and all these tracks, different tracks coming up, going up and down. And then we have different types of cells. And the cells in white matter are different, and the cells that are in gray matter are different. Then, though there are a few common cells that are present in both the types of gray matter of the spinal matters. Now, which are the cells that we find in spinal cord? Because these cells later on decide how the progress of the injury or the damage extension is going to be, whether it can be controlled and how it should be controlled. So neurons, we have the neurons, that different tracts. Then we have glial cells. So glial cells, astrocytes, microglia, oligodendrocytes, a small population of endogenous stem cells, oligodendrocyte progenitor cells, and ependymal cells. All these cells have their own role to play. Like astrocytes, they help in the keeping the composition of the spinal fluids and the ECM, extracellular material and extracellular fluid, by playing their role in the spinal fluid barrier and maintaining blood-brain barrier. That is in case of brain. In case of spine, it is blood-spine barrier, neuronal survival, synapse formation, strength, and turnover. So these roles, when they get disturbed, the injury extension is there, and we find that the damage increases or it doesn't heal that fast. Now, pathology of spinal cord. There are two phases. Primary mechanical injury is the trauma, direct, and subsequent cascade of autodestruction. Because when the response to the injury is there is autodestructive damage. Now, mechanical trauma, the direct trauma usually causes axonal damage, neuronal cell death, blood-spine barrier disruption, and extracellular matrix degeneration. Then cascade of secondary injury. When inflammation of the lesion site, edema, ischemia, vascular dysfunction, excitotoxicity, electrolyte shift, demyelination, lipid peroxidation, Wallerian degeneration, free radical production, fibroglial scar, postponed apoptotic cell death, and finally causing a cystic cavity formation. So this is the whole mechanism how in the initial phase and later on the damage progresses. Now, when we talk about the duration, the spinal cord injury can be categorized immediate SCI. Means the very few early hours, that's the primary injury. And the aim here is reduce the cell death. Second stage is acute spinal cord injury. That's within a few days after the injury. There are inflammatory reactions. The body is responding to the injury. And what we want is enhanced neuroprotection during this phase. When it goes to subacute spinal cord injury, that means weeks to months, there is tissue modification. And so we need to do some tissue remodeling while the body is doing the tissue modifications. Last is chronic spinal cord injury that most of the rehab cases we see are in more than 6 months time, glial scar formation and repair via neuroplasticity. So stages are detected by MRI, electrophysiologic evaluation, biomarkers, and secreted into the serum and CSF. So these do help in determining where exactly the phase has reached. Neuroprotection, because we need to protect to counter the progression of the secondary injury. We have the pharmacological agents. These pharmacological agents are being tried that are methylprednisolone, minocycline, and cyclosporine. These, though, are being tried but have not been found very useful, and they have not been able to serve the purpose what for they were thought of. And antioxidative enzymes encapsulated in biodegradable nanoparticles help in preventing secondary damage. These enzymes are injected as well as pass to the spinal cord through blood in nanoparticles, and they are also being tried. Hyaluron-based hydrogen loaded with fat extract induced microglia or macrophage polarization, alleviate inflammation. So these are for reducing the inflammation. So we see that the research is going on. Some success has been we have been able to achieve, particularly in animal models. But in human, the wait is still long. We have to keep on working to reach a stage where all these we have some material that can lead to proper neuroprotection. Tissue engineering strategies that also can be used. Biomaterial scaffolds. Biomaterial scaffolds, they provide the structural support sort of thing. The spinal cord is damaged and we use these for that purpose. Biomaterials as a filler or mechanical stabilizer. This extracellular material, they reconstitute that. And condition for conduction with the host cells, so that there is some realignment and the conduction starts. Biomaterials such as hydrogels can supply trophic and physical support. Then biomaterials, collagen, hyaluronic acid, fibrin, gelatin, alginate, etc. are also being researched. Advanced three-dimensional bioprinting for SCI repair. The printing also is being tried now. Cellular strategies, molecular strategies, along with tissue engineering strategies are also being researched. And we hope that in near future, we'll be able to get something that is quite helpful in enhancing neurotrophic support to provide a growth permissive environment. Right? The means for axon regeneration, so that the axons regenerate and they are able to come out of the injured the effects of the injury. So intrinsic mechanism that controls primarily the axon regeneration are ion channels, signaling pathways, cycloskeletal dynamics, transcription regulation, and epigenetic modulation. These intrinsic mechanisms that control can be affected from outside, and when they are affected from outside, that effect will decide whether it's going to be positive, negative, can help in recovery, or it can lead to damage. Cycloskeletal arrangement and axon growth cone formation. Axon growth cone formation is very important. Enhancing the SNPH, syntrophin deletion for mitochondrial movement. Because mitochondrial movements become less or they completely stop in these cases. So for that, this rearrangement does help, and creatine administration for axon growth is also useful. These things may look slightly out of the context as far as rehab is concerned, but unless we understand the spinal cord and the mechanisms after that, the patients coming to us at different stages, we will not be able to do the justice with the management. And if we are very well aware of the things and we know how the mechanism is taking place, we can contribute in the recovery more than what we can do without knowing. Now, pharmacological therapy, methylprednisolone. This is the medicine that people have been saying for years altogether that is very useful. It acts as free radial scavenger, reducing inflammation. But it is still controversial. People use it. People have used for years. And there are different regimes. How much time it should be given, how it should be given, whether it can be given oral, it has to be IV drip. All that is there. And then it has got its own side effects as well, particularly gastric side effects. So simultaneously take care of, because stress is there. The patient is already stressed, and over and above, we are giving methylprednisolone injectable through IV. So gastric disturbance and the bleeding, all that hematemesis, etc. We need to take care of that. That's why people are still not in favor of considering the minimum efficacy and many side effects of this. NMDA, N-methyl D-aspartate, receptor antagonists like magnesium, decrease inflammatory and toxicity effects. So magnesium, when given, reduces edema, vascular permeability, and lipid peroxidation. It is still at the research level being tried in animal models, and people have found that it is useful. The anti-inflammatory drugs like brufen, non-steroidal type, they suppress prostaglandins, and they also have been found useful. They can be used in humans as well. People have tried using them. Some say that they have but there is no significant research that has gone into that. Few of the anti-inflammatory drugs, non-steroidal, which have been tried, have not been found useful. Ion channel antagonists, calcium channel blockers like limodipine. Again, methylprednisolone also acts as ion channel antagonist. Dextron, sodium channel blockers, and even potassium channel blockers also improve neuroprotection of white matter and improve functional results. SCI pain treatment, tramadol, lidocaine, cannabinoids, topiramate, selective serotonin, norepinephrine reuptake inhibitors, pregabalin, gabapentin, and cyclic antidepressant, etc. So all these treatments are being tried for improvement as well as for preventing the pain or the treatment of pain. Surgical therapy, surgical interventions improve the outcomes if done in first 24 hours. Obviously, they are helpful in stabilizing, reducing the pain, early healing, all that. But when it comes to neurological recovery, surgeries have really not been found very useful, except they say that overall, if there is some, and that also very few, not very few, only 1 or 2 studies are there. They say that if the operation, the surgery is done within uh, uh, either 8 hours or 24 hours, there is still controversy in that. But if it is in 24 hours, so the level of the spinal cord can be changed to 2 levels. Nerve repairs, this is also being tried because spinal cord injury doesn't only lead to damage to the spine and spinal cord, nerves also are damaged, particularly those nerves that are coming out. Bridging the nerve gaps with acellular nerve grafts is feasible. Sutureless repair using fibrin glue is also being tried. Allografts have been found useful in reducing pain and restoring functional level of sensations in chronic patients. So surgeries, if done in initial phase, are useful, but not greatly when it comes to neurological recovery. Cell therapy. These cells, I'm talking about the stem cells, which is very popular these days. These undifferentiated cells are capable of differentiating in specialized cells. And so they take up different functions, the specialized functions. They have the ability to self-renewal. Means one dies, other comes. Or to multiply while maintaining ability to develop into other cells, even when they are become differentiating into the specialized cells. Cell transplantation, regeneration of glial cells and neurons. That's the purpose of cell transplantation or the cell therapy. Regenerative cell therapy for spinal cord injury uses, we can use many types of cells, and the common ones are embryonic stem cells, hematopoietic stem cells, and neural stem cells. Stem cells can repair dysfunctional or damaged tissues by administering the therapeutic agents. And these cells are set to do that. They release something that leads to this type of advantage. Cell therapy with intravenous fusion of mesenchymal cells improves functional outcomes in SCI. These are being tried, and their animal models have shown some improvement. In humans, people have been trying, but no significant advantage or no significant benefit has been found. Other methods of cell therapy are intrathecal injection and intramedullary injections. So can be given either in the form of intravenous infusion or intrathecally or intramedullary. Blood flow restriction. This slide should have been taken later, but let me tell you what exactly is this. A technique that uses external pressure to restrict blood flow to a limb while engaging in exercise. This is being tried that you stop the flow and there is recovery through the neurons. BFR has been shown to be safe in use with the people with SCI and even those with having the autonomic dysfunction. Neuromodulation. This is one of the popular things that is coming up, and some useful researches that have shown that, these can be used, have been done, but a lot of work is still to go into it. And not all of these what have been mentioned here can be used for each and every patient. This is what is neuromodulation? A bioengineering approach. Modulation is change. So that utilizes electric or mechanical stimulation, pharmacological agents. So neuromodulation can be done by mechanical stimulation, pharmacological agents, optogenic and chemogenic genetics to modulate neuronal activity. So not necessarily through currents or magnets. Aim is to develop control over paralyzed lower limbs or upper limbs, reorganization of spatial circuits. DBS, deep brain stimulation, transcortical magnetic stimulation, TMS, transcortical direct current stimulation, TDS, brain machine spine interface, have achieved unexpected efficacy in restoring locomotion and volition controls both in animals and humans. And some of these are FDA approved as well. Now, spinal cord stimulation, a potential therapy to alleviate neurological deficit and promote recovery in spinal cord injury. What are the types? Epidural electrical stimulation, where the electrodes are kept in the epidural space. So this is invasive. Transcutaneous spinal cord stimulation, TC-SCS, and intraspinal microstimulation. Applied to lumbosacral segment, they have been shown to substantially restore locomotion and motor control in spinal cord injury. When gravity eliminated exercises are done, they have said that the improvement slightly better, but they are still under trial. They have not been approved for prescribing, particularly for spinal cord injury. So spinal cord stimulation is being used for pain regulatory purposes or pain control methods, but very few people, very few literature is there where they have seen significant recovery using the spinal cord stimulation. Transcutaneous spinal cord stimulation, which is one of the spinal cord stimulation, restores motor, sensory, and autonomic functions. This is non-invasive, inexpensive, and easily available. So can be preferred than before going to the invasive things. Intraspinal microstimulation. So electrical stimulation with surgically implanted electrodes. It is still under trial, not yet suitable for use in humans. It can be wired or wireless and can lead to motor or autonomic recovery. So being tried for in all these, for recovery of motor and autonomic system in animals, and there have been some encouraging results, and soon we may find being tried on humans. Brain stimulation. Brain stimulation already being used for different purposes, particularly psychiatric disorders, Parkinsonism, etc., etc. And well-established therapy. activates neural activity of the target brain region via implanted electrodes. It is a surgical procedure, and the electrode goes like the red arrow inside through a burr hole. And that particular area at the tip, this has the sort of two electrodes together, and the end of this, wherever it lies, that stimulates the area. So different areas of brain can be stimulated using the DBS, deep areas of the brain. So this is the red arrow is showing the intracranial electrode, and the site is not only this, it can be in any direction, any place, depending on the where exactly we want to place the tip of the electrode. Pulse generator battery. At the end of the tip of this arrow is at the site of the area to be stimulated. And the other end of the arrow that comes under subcutaneous tissue all along through the head, neck, face, neck region, and the electrode, the lead comes to the subclavian region below the clavicle, where the battery is there, the stimulator is there, from where the stimulation is done. Transcranial direct brain stimulation. Why I am telling this, you may be surprised to see why brain stimulation is there, but brain stimulation has been found useful and is being tried in case of spinal cord injuries. Transcranial direct brain stimulation, subthreshold polarization of neuronal membranes, and is capable of modulating corticospinal excitability to muscles. That's why brain stimulation. It's a non-invasive, it's a direct current procedure. So electrodes are used and they are placed outside on the skull. Relatively safe technique of the brain stimulation to regulate neural activity in motor cortex, and has shown that it is useful to mitigate pain and improve respiratory function in case of spinal cord injury. So again, a promising modality that we may find useful in the coming times. Transcranial magnetic stimulation. The violet thing that you see is the magnet. Non-invasive technique of brain stimulation to promote neuroplasticity. So the magnet stimulates from outside and leads to current inside the brain, and that current leads to the polarization of different parts. So current and then different currents being conducted throughout the brain in different directions, that may be by the sides or under this. Neuroinvasive modulation techniques which directly perturbs neurological firing, neuronal firing, and ongoing network activity of evoking action potential in the cortex. Now, RTMS. TMS can be single pulse, and it can be repetitive transcranial magnetic stimulation. When we say single pulse, good thing about is that the effect can be measured. The evoked potential can be measured, and the graph can show us how much current is required to generate the potential and how much is the lazy period after that. So all these things can be evaluated simultaneously. So it is very useful for research purposes and see the effects. So repetitive transcranial magnetic stimulation means this can be, usually it is single pair and single stimulation, it may be paired, But most of the times it is the repetitive TMS that is used or that has been found useful clinically, and people are trying in case of spinal cord injury also. So it is new non-invasive neuromodulation techniques. You can see that magnet is kept overhead, which directly perturbs neural firing. So it induces synaptic plasticity. Brain-machine interface. Again, a promising stimulation technique. A novel technique that combines engineering, computer science, and neurophysiology. It is really promising, and it is going to be the thing to restore sensory motor functions in patients with neurological disabilities. There is a computer outside. The stimulation electrode is placed inside the brain. It can be stimulated from outside as well. It can generate its own potentials whenever whatever is planned. So all these modalities are there. And then a computer picks up the signals, right, and then translates into different activities. Brain-machine interface involves pairing of assistive devices with a brain signal recording device. So brain thinks something, thinks about moving the hand, and the assistive devices based on the signal start moving. There is a recording device that may be surgically implanted within the individual skull or placed non-invasively over the scalp, as I told you earlier. The recorded brain signals are decoded and turned into an instruction to control the assistive device. So what we have in brain-machine interface, there is something that picks up the signals that are generating in the brain, and that may be implanted receiver, or that may be receiver outside the brain that has been mentioned here as recording, and that goes to a system where it is analyzed, decoded, and then it goes for translation into the assisted device. So there will not, and the day is not far when a person thinking will be able to move the hand, which will be computer controlled. When implanted, can provide a direct connection between human brain and a computer and translates brain activity signal into control signals for external device. So a BCI system, brain computer interface, does what it does is signal acquisition, signal pick करते, takes the signal from the brain, feature extraction. What feature exactly is required by that signal? Then feature translation, that is converted into the signals, and classification output, which interface to an output device. An output device may be in the form of assisted device. Wearable robots. So we have seen that all these engineering things are becoming useful. Brain stimulation, spinal stimulation, and then we have the wearable robot. Robotic significant growth owing to its development in why suddenly AI is really developing very fast. And in that segment, robotics use uh, for persons with disability, neurological deficit, are being tried at a very large scale. And recently, because there is development in sensors, the sensors are being modified, the smaller sensors are there, better sensors are there, actuators that actually perform, miniature computers and control system softwares. All these things are being developed. And this development, and they are seeing a fast development, both in the scale as well as the quality, and the engineering know-how is improving in these areas. So wearable robotic skeletons developed as assistive devices. So exoskeletons or robotic exoskeletons that are being used, which can be worn by the person, are being used for rehabilitation purposes. And these can be for upper extremity or can be for lower extremity. They help in regaining balance, coordination, strength, and help in motion also, particularly for large muscles of hip and knee. These robotic assistive devices or exoskeletons can help the brain and spinal cord work together to reroute the signals damaged due to spinal cord injury. So that's how not only they are directly useful when applied to the extremities, they are helpful in recovery of the spinal cord as well. But again, the research in this direction is still not satisfactory one, and they are very costly. Two, they cannot be taken out, they cannot be used socially. So the role is not that great still. It is being still being tried, and unless the price comes down, the weight comes down, and these have the side effects as well. The problem is we think that these wearable robotic exoskeletons, they are moving the limbs. So they are very useful because they are moving the limbs. But we forget that they are moving the limbs, they are not moving the muscles. Muscles are not being moved. Joints are being moved. So when the muscles are not being moved, they are not being exercised. So whatever the effect that passed through the muscles to the brain, the stimulus that goes through the muscles is not there. Yes, there is the proprioception through the joint that is passing to the spinal cord. Again, the bones. Yes, the movements are there, but bones become weaker when the muscles are not active. So when the muscles are not active, how can the wearable robots be useful for bones? And spinal cord injured patients, they have weak bones comparatively. Osteoporosis takes place in them, and they need exercises. So they are not as useful. Then obesity. Well, India, that way we are, for the time being, we are lucky, though obesity is increasing very fast in our country also. In Western countries, they say that majority of the spinal cord injured are obese. And for them, wearing all these, fitting, changing the size requires time and adjustments. So these costly things appear very lucrative type, and we think that they are computerized and latest, so must be very useful. And no, still there is a long way to go. Weight reduction has to be there, muscle stimulation has, yes, if used along with FES, they are quite useful because FES stimulates the muscles, but the synchronization has to be there along with with the exoskeleton. Now, as we saw variable robots, exoskeleton, we find that they alone are not that useful. If we combine them with FES, they are useful. Similarly, if we combine with medicines for reducing the pain, they are useful. If we combine them regenerative therapy also, they become more useful. So combination of strategies is very useful and is the thing that should be tried, because still till now we do not have anything that we can say, oh, this is the therapy, if we use, the recovery will be there. And this combination also is being tried. We have not reached the conclusion still. So target diverse aspects of spinal cord pathology. There are biomaterials that act as key component of combination strategies. They provide temporary storage. Means those biomaterials like slow release things in the spinal column, inside or outside the spinal cord. So they keep on working long-term treatment strategies. Bioactive molecules, transplanted cells to modulate inflammation. All these, they modulate the inflammation, they change the neuroplasticity, axon regeneration, so and cell survival. So if combined bioactive molecules, biomaterials being there, then current therapies being stimulations there, robotic, all these can be very useful. Then another thing, virtual reality neurotherapy means befooling the brain that you're working. So virtual reality is, again, it's non-pharmacological, non-invasive, minimal adverse effects. And this therapy is designed to promote activity based on exercise program. That the exercises are done using virtual reality, and that leads to recovery. The exercises do not only affect the muscles, they do affect the spinal cord. And there are different ways in which the spinal cord is stimulated for recovery. Activated brain mirror cells, mirror neurons that use the neural pathways and execute goal-related neurons. These, the VRNT, activates brain mirror neuron cells. Good efficacy in improving sitting and standing balance have been found useful, right? Though the studies are still going on. Being tried for SCI-associated neurological pains. When the pain becomes resistant, virtual reality has been found useful because this is non-pharmacological and it has got some psychological component. It diverts the attention. So earlier people used to say there may be pain and gate control theory activated, but still there is a lot to be understood about the utility of virtual reality in spinal cord injury. Functional electrical stimulation. This uses computer technology to send low-level electrical impulses to specific muscles that we all know. What is new about is this is now being tried with other modalities, right? And can improve arm as well as muscle strength. And this improvement in arm and muscle strength is conducted up to the spinal cord from where the stimulation for recovery is utilized over there. External motorized or robotic devices. This I think we have covered. Let me go to exoskeletons and robotics. Yeah, let me deliver high volume. This is for approximity when we talk about Robotic exoskeleton devices align with and support with artificial joints. There are also two components of robotics. One is exoskeleton, which is the support system. It does move when the the robot is guided by the computer. And robotic end effectors, the end effector that performs the activity. There are currently 6 robotic devices in the market when it comes to the upper limb rehabilitation tools. Armio, In Motion, and the Hand of Hope, Rio, Go, and Arm Light exoskeleton. Ambulation with the use of exoskeleton as exoskeleton assistive walking is also being done. This is a photograph of Armio. And if we see this, this is the long thing is exoskeleton. And the end here, it acts as the movement generating thing. And if we had the hand component also, then that would have been the effector or a part of that particular robotic system. Body weight supported treadmill training. It has got, people have claimed a lot about it, but ultimately what has been found out, it has limited use. It has some problems also because it is not portable, not used for community ambulation. But it is useful when it comes to spinal cord injury stimulation, the recovery generation. So it is a rehabilitation tool, though challenged extensively, but still being used world over by many centers. And it does have some role, particularly in range of movement, maintaining the range of movement and stimulating the proprioception and leading to some recovery that is being studied. Activity-based rehabilitation focuses on repetitive weight-bearing exercises that simulate the nervous system and encourage functional recovery. So activity-based, that do a lot of activities, and that will lead to recovery. If combined with functional electrical stimulation, they have been found further useful. So improving the strength, rebuilding the strength, or achieving the coordination through targeted physical therapy sessions. This has been found that if you do repeatedly, the repeated exercises are useful. High intensity gait training. Ability to walk is the top priority. The patients, usually the paraplegics, they want to walk, and when they want to walk, they require the extremities, and gait training is important in cases of incomplete SCI. So gait training with different assistive aids is very useful. And if done high intensity, why it is being mentioned that particularly at high intensity in people with chronic SCI, gait training has been found useful. And high intensity gait training, how we decide is that 60 to 80% of patients' heart rate reserve. Means it should increase to that level. Then we say it is high intensity gait training and it will be useful. It will fall into that category that has been found useful by some of the researches. Nerve and tendon transfers. Now, 70% of the patients with tetraplegia who underwent surgical approach have shown improvement functionally. So tendon transfers are becoming very popular because there are no other modalities that have been found that useful. Simultaneously, nerve transfers also are gaining support due to potential for recovery of more than single muscles. So where one segment above is available, the segment below is not available. Nerve transfers have been found useful and are being tried, and they are also gaining the popularity. Acupuncture, exercise, massage therapy, they all have been found useful. As I told you, exercise, similarly massage therapy and acupuncture by inhibition of inflammation, oxidation, apoptosis, improves sensory motor functions, stimulates axonal sprouting, nerve regeneration, can protect the micro environment of damaged neurons. There are multiple ways acupuncture uh, uh, leads, leads to some recovery in that uh, degeneration process, makes the things better for the patient. And it has been found useful through the different researches that have been done, particularly in China. Though, again, not a therapy that one can recommend straightforward, go for this. Urinary bladder growth nerve factor elevated in detrusor activity. Overactivity needs to be controlled. So research is going on. Nitrous oxide is agonist, like nitrates taken for angina, all these, they are also being tried. These reduce the urethral pressure. Neuromodulation for detrusor overactivity, unilateral bilateral sacral root stimulation. Though it is being done, it has got its own contradictions and contraindications and side effects, and has not been found useful for a long time. Not more than 1 to 3 or 4 years. After that, the effect is not there. So all the surgery, and there is pain at the side, the electrodes, wiring, the cable, that leads to problems. There are many things associated. Combining dorsal rhizotomy to reduce detrusor pressure and sacral root stimulation, it has its own role, in particular in females, but male retrograde ejaculation is a problem. Chronic pudendal nerve stimulation is another thing that is being tried. So all these things are being tried, but still we are eagerly waiting for something that is, yes, this is useful, this is the therapy, or this is one of the therapies that should be tried.
Thank you so much, sir, for a wonderful presentation. I know it is difficult for a vast topic to be uh, to cover
What
up
this is,
in an hour, and I'm sure this is a
how to go back
wonderful
is, uh-huh.
learning for all of us. So now we can take few questions, and I don't see, you can, all of you can write your questions in the chat box.
Ma'am, chat is disabled.
Chat is disabled. Asmita? Yeah, I can see the chat disabled. Asmita?
Yes, ma'am, I'm there. Just doing that.
Yeah, can you enable the chat, and in the
Yes.
meantime, because all of us can ask the questions, you can ask, even raise your hand and ask the questions.
Now they can drop a question on the chat box.
No questions?
Yes, sir. So there is one question from Abhinav. He's asking
Stem
about
cell
stem
outcome.
cell outcome in SCI.
Yes. Stem cells, the researches till now have shown that in animal models, they have been found useful. In humans, it is still no. Though it is being tried, That's just at the research level, not for to be used as practical therapy for improvement. Though people have been trying, but it has not been recommended as a therapy for spinal cord injury.
Yes, sir. So just to add to that, there is a multi-trial is happening where in US, China, and other parts of the world, where they're using the stem cells, embryonic stem cells, just at the level of injury after doing the imaging, and find out where there is a loss of the neuronal network, and the neurosurgeon, he injects at 4 points, 2 above and 2 below the injury, and then followed by extensive rehab. So the pilot study was conducted in China, and now the study is going on. So let's see if there are some results, whether it's still now, as you say, it's still in the experimental stage.
Yeah, some positive outcomes are there, but they're not enough.
Yes, sir. So, and everyone nowadays, they have started doing stem cell, IV stem cells, and I think so they are not the true stem cells. So let's see what the future has for us.
Yes.
Any other questions? No questions. I think so. We take it in a positive way that everything is understood by all of us, right?
Let's
All
hope.
the participants. So, I think this was an extensive, all the advances, sticking
The
to the
topic was
advances.
quite big, so
Yes,
going
sir.
through going to the details was not possible because
I
already
understand.
it has taken 1 hour when it was kept to the minimum.
But then we have covered. This is a eye opener that the PGs can go and learn, and we have this in the groups. You can, if you have any questions when you go back and you read, you can definitely message us. We'll be there. We'll take it to sir, and then we'll get back to you. But this was really very extensive and very much eye opener for all the PGs, I'm sure. And okay, missed half of it, so we are sorry for that. But I think so. The network at your area would not be good, stable. So the next, Asmita, can we have the next seminar? Can we share the slide for the next? Okay, so the next one is we invite the second, continuing with the sessions, the monthly meetings of MAPMR. The second one is advances in stroke rehabilitation from Dr. Abhishek Srivastav on 12th of June. This will be probably in the evening time. So once you finish your work, this was also, we had around 665 participants, and I'm sure they must have had a nice academic feast. So with this, we'll try to share, we'll ask the presenter if they consent for, someone is asking that if they can share, if we can share the presentation. So we'll ask the presenter if they consent, we'll definitely forward it to you regarding the presentation.
Can be shared, I don't mind.
Yes, sir. Okay, sir. Then we'll take it from you, and then maybe we can share it because it is really very much informative. So thank you so much, sir. Thank you for taking out your time and then sharing this knowledge for the advances in SCI. And we take it that this is a really eye-opener, and this has started with a bang, and we want it to continue in the similar fashion. And the next, we invite all of you. You can spread the message for the next seminar on 12th of June, which is advances in stroke rehabilitation. And with that, thank you, sir.
Dr. Navita, I think MAPMR from my side and the organizers, particularly you, that you have actively participated and conducted the webinar. Thanks a lot.
Thank you, sir.
Yes.
Thank you, sir. We were thinking it from a long time, but from when you were the president. So thank you for guiding us, and I'm sure we'll take it forward in your guidance.
No, president is doing a better job.
No, sir. It's all your guidance
Okay.
that we are doing.
Bye.
Thank you so much, sir. Thank you.
Okay,
We
bye.
appreciate it. And we'll wait for the second webinar. And the questions, we still have time. You can message to us and we'll take it forward. Thank you. Thank you, everyone. Thank you, participants, for sparing your time and then learning from the stalwart, Dr. Anil Gaur. Thank you, everyone. Thank you. And thank you, Amit. We still can't hear you. Is your connection okay?
Thank you,
Amit is
everybody.
muted, I think.
Thank you.
Okay,
Thank
thanks,
you.
Dr. Abhishek, for being there. Amit is still muted. No words
I
from
think
him.
No, sir, sorry, there was a
Yeah.
problem with my mic. Sorry, sir.
Yes. Yeah.
Yeah.
It is. Thank you, Dr.
Yeah, thank you,
Abhishek.
ma'am. Thank you,
Amit.
sir.
Thank you.
Thank you, everybody. Thank you.
Thank you. Thanks. Bye.
So this is what it looks like.